otherwise healthy without issues, we notice that there's a twofold higher increased mortality noted in our patients compared to the reference US population here in the orange. The major cause of death after recovery from acute TTP was cardiovascular disease, and this was reflected in both the Oklahoma registry as well as a combined cohort from Johns Hopkins and Ohio State, followed by TTP relapse as being the number 1 and 2 causes of death. Some risk factors for early mortality in our patients include male sex, increased age, and an increased number of TTP episodes. But remarkably, traditional risk factors weren't reflected in the multivariable model. And so this raises questions, are there TTP-specific risk factors which may contribute to mortality? When we look again at this ADAM-TS13 cutoff of 70%, we see a separation of the curves. However, the numbers of patients who experienced mortality in follow-up was fortunately small, and so this didn't reach statistical significance. So what are some factors that may influence these different types of events? And we know that age, diabetes, race are associated with the development of major adverse cardiovascular events, but this is likely multifactorial. And even things like race, we have to understand, is a social construct and may only reflect the underlying inflammatory or other changes due to chronic stress that may be occurring. So some of the potential hypotheses for why vascular disease appears more predominant in TTP survivors may be from this reduced ADAM-TS13 that we see during clinical remission. Perhaps there's ongoing subclinical injury due to increased ultra-large von Willebrand factor multimers or microthrombi, things that can increase endothelial damage in both the heart and the brain. The higher frequency of African American race, autoimmune conditions, or traditional risk factors is also seen in our patient population, and it may simply be that these factors themselves increase the risk in our survivors. Accumulating injury during the acute events may also explain why the increased number of TTP episodes may be driving this, and there may also be other drivers of vascular injury or inflammation that are seen in patients with underlying autoimmune conditions that may contribute to this. This does beg the question that does preventing additional endothelial damage during an acute episode potentially improve these outcomes? And we'll talk about that more later during a discussion on acute therapies. The last study that we'll leave you with is one that we've recently done at Ohio State, where we examined cardiac MRIs, stress perfusion tests very specifically, in TTP survivors. And we examined this in 15 survivors compared to just normal controls who received a cardiac MRI for another cardiac indication, but who had normal stress perfusion. So there were no differences in the rest perfusion seen here on the right. And perfusion is specifically, it's a heat map. So the more bright or yellow or the color looks, then that's the more blood perfusion going through the myocardium. And when we look at the stress images, on the bottom, we see the control patient who has the entire wall of the myocardium lighting up very nicely. However, in the top row, we can see that the TTP patient has less perfusion in the subendocardium specifically when compared to the control patient. What this really tells us is that there were significantly reduced myocardial perfusion reserve. That is a number ratio that essentially demonstrates the heart's ability to relax and to have the coronaries fill up to their maximum potential. And this is impaired in patients with TTP. And this occurred really regardless of what the ADAM-TS13 activity level was in remission. And this signals to us that these patients likely have some underlying endotheliopathy or vasculopathy that may be contributing to these cardiac and stroke events that we see. So the take-home messages here are that TTP survivors are at increased risk for heart attack and stroke, and this may be related to reduced ADAM-TS13 activity in remission. TTP survivors should be followed longitudinally to importantly prevent relapse, but also address some of these long-term complications. And we really need to make sure that we're addressing these underlying risk factors and modifiable risk factors for cardiovascular disease specifically. And we should be screening and aggressively managing these, even in patients who may not traditionally fit that mold of a 60 or 70-year-old male smoker, kind of vasculopath patient. but more so the young woman patient who may come in with TTP even in their 40s, and you may not traditionally think of having as cardiovascular disease. We need to make sure that we're aggressively screening and managing those patients for these complications.